Without further ado, I'll go over to the presentation. I have no financial disclosures relevant to this talk. So, as a surgeon, we are dealing with cerebral pathology, especially tumors, but neurosurgeon is quite diverse. And we deal with trauma, infection, sometimes with demyelination, degenerative processes, and tumors as well. Vascular, as we have gone through quite a bit, neurointervention has taken over the most intricate part of neurosurgery, which is vascular surgery. But again, it's a combined effort. And I know that neurosurgeons and neuroradiologists are supposed to be good neighbors. So from our point of view, we need to know what is the pathology. And again, it's a joint effort how we get there. And where in the nervous system is the lesion. So short of doing all the sophisticated stuff, we'll come to that, how we get there. And once we have the diagnosis, is a neurosurgeon really required or not? That's another step. So, how did we get neuroradiology? It was, in fact, a neurosurgeon, Arthur Schuller, who was tied up with this idea of how to get to know what's inside the cranium. And he was looking at operating on pituitary tumors. And with good mentors, he collected a complete book, wrote a book entitled Radiology of the Diseases of the Head. And his contributions at the very outset start looking at plain X-rays. And what we could actually see is the cranium, some bony parts, and then the pineal calcifications, choroid calcifications. And he got to know that certain tumors will calcify and will even show up on plain X-rays. So in those days, we had advanced pathologies. People would go around with symptoms and signs without any treatment, and eventually come to the healers who had very primitive tools of X-rays and then primitive surgical tools that would deal with them. And of course, the diagnoses were imperfect and the mortality post-intervention was quite high. And then there was these findings of chronically raised ICP and osteoporosis circumscripta. And then in terms of neurosurgery, it's been practiced since several thousand years back, where people thought that the seat of certain diseases, especially dementia or behavior and the likes, was in the brain, and letting a bit of blood out would heal them. So people have been putting tools to the head for the sake of healing for many, many years. But I don't think we can practice this anymore. So then we come to the era of Walter Dandy. Again, a neurosurgeon in his quest for finding the intracranial anatomy, localizing lesions, did radiographs and plain X-rays of the head, and he found abnormalities in 45% of the patients. So ventricular anatomy, another step forward, ventriculography, injecting air through the lumbar subretinal space, and then taking pictures. Again, an asymmetry of the ventricular system pointed to where the lesion is roughly as it related to the picture of the ventricles with the air contrast X-ray. Excuse me. And short of getting our advanced CT scanners and MRIs, surgeons got another tool in the hand with the help of the radiologist, and primitive slide motion imaging was there, and frame shift wasn't possible until we had the advanced cameras. So with these, we could again get good pictures of the cerebral angiograms and see where the displacement was for specific blood vessels, especially in the intracerebral and middle cerebral artery distributions, just giving us a rough idea where to go, where is the lesion, and following that, we come to the new era where there was a profusion of knowledge, an explosion of the techniques that went way ahead of the era before 1927. So we have CT and we have MRIs, two different modalities with two different ways we look at the brain and the cranium. So from our point of view, it's very simple. We're looking at calcification, craniofacial abnormalities, hemorrhage, hydrocephalus, mass fact shift and herniation. We look at the density, enhancement, and cysts. So from our point of view, if we have an acute pathology, somebody who has a brain tumor is going off, we don't have time for an MRI. Yes, CT is a wonderful modality. It will give us, by and large, 90% of the information. If we have to do an acute intervention, that is enough. So somebody who is GCS 8, has a hemiparesis, has been having a headache for a while, putting that patient to an MRI or arranging an MRI in the middle of the night is not the right thing to do. CT is enough for us, and we go with that information. Having said that, if we need further information, we can do that after we have tided over the acute situation with surgery or medication. So with MRI, we have detailed anatomy, especially the gray-white matter interface. We have seen in the previous slides how the gray matter and the white matters, thalami, projections and association fibers are very well delineated. Even with the T2 MRI, we can see the venous and arterial anatomy very well, and their relationships to the lesion that we are dealing with. Different types of tumors have different parameters on the various sequences that we use. And that can, especially with the help of a neuroradiologist, we can go to them and discuss what are we looking at. So, different tumors can appear similar but have subtle differences that will help us in our planning for the intervention. So tumor and other diagnosis, that is a very important differentiation that MR can help us with. Diffusion tensor imaging, again, a very advanced modality. I'll come to that. Biopsy targets. So at times we are dealing with very small lesions, and we need to know where is the target. The tumor has a heterogeneity within itself in terms of enhancement, edema, cellularity, and there are different MR imaging modalities that will help us in targeting the specific area where our biopsy is going to be most informative and give us a positive yield. So if we are in a flare area without any cellularity, we may be at the edge of the tumor and the biopsy may come back negative. But if we have a target in the form of enhancement or increased diffusion restriction or increased perfusion, all those parameters will help us in going to that actual area. And with MR and CT guidance in OR, with the stereotactic biopsy, we have a 1 or 2 millimeter of accuracy now. So we have the target as defined by MR and CT, and then we have our tools to get there and get the right diagnosis. MR spectroscopy. So again, there are lesions that are quite deep. At times, there are difficult targets, and MR spectroscopy will help us in defining, is this an abscess? Is this a tumor? Is it a high grade? Is it a low grade? So again, there are so many sequences now in MR that, of course, the neuroradiologists can apply and help us with our differential diagnosis. So I won't dwell on these. As Dr. Ahmed said, we need to speak to the patient, and get the required information. History is the cornerstone of any diagnosis, and the radiology aspect comes last as an add-on to refine that and make our planning. So I think we are losing on these aspects of our training, but we need to go back and look at our patients before do any investigations. So this is the crux of the matter. Patients walk into our clinic and say, we say hello to them, and they say, Dr. Saab, this is my scan. And we say, well, put it in your pocket and let's chat. So that's very common now. And at times it works very well, you know. Our public is doing a wonderful job at using these ailments. But at times, and then it becomes a double. So we need to go stepwise, take a history, examine the patient, or order whatever biochemistry, hematology we need to do, and then go through the radiology. So this is what we're looking at in terms of scanning. Common pathologies, hemiparesis, or increased ICP, headache, nausea, vomiting, could be one of these diagnoses. So hematoma, maybe low platelets, very common in our setup. Patients undergoing chemo, platelets down to 0, will have a spontaneous bleed. Infection, again, very common here with patients undergoing treatment with immunosuppressive drugs. Degenerations, Dr. Amir has already alluded to, chemos do cause degeneration. Inflammation, again, very elusive to diagnosis. Contusions, sometimes traumatic, yes. Ischemia and infarct. So all these pathologies will have a common clinical presentation, we know that. And tumor and treatment-related changes. So coming to the tumors, some of them will have an area of necrosis. With treatment, will have pseudoprogression. With some new chemotherapeutic drugs, there will be increased enhancement. That is not actually progression of the tumor, that's a treatment-related effect. And if we don't know the history and in the examination, and we haven't studied the notes from the oncologist, when did the treatment start, and is that a known side effect, we may miss the diagnosis. So we need to collaborate at each step. Response, partial or complete, again, MR will help. And then a tumor recurrence. This is the information that we are looking at. So I am a victim of poor information here and elsewhere as well. Our requests for diagnosis are very, very erratic and irrelevant. Treated 4 years ago, follow-up scan. That's not the right request that we need to do when we are requesting information for our neuroradiologists. We need to have a good history that we had surgery, we had radiation 2 years ago, and now the patient is on PCV chemotherapy. And is this progression? So this is what we need to request from our colleagues. And then we get the right answers. Otherwise, we're in the dark. So brain tumors and tumor-like conditions, intrinsic tumors, metastases, vascular, quite a few of them. Some of them we touched earlier in our talk. So in terms of the surgical anatomy, I dare say we are, as surgeons, good enough looking at the sulci gyri, the blood vessels, sinuses, and all that. But at times, we'll go back and discuss with the neuroradiologist, what are we looking at? Is this an anomaly? Is this just an imaging finding? Is this anything significant? So at times, we will get their help. Intraaxial and extraaxial, we can figure out very well. Vascularity, again, going back to radiology, there are certain sequences that will tell us how vascular the tumor is. Sometimes flow voids are very obvious, but there are certain signal changes on MR sequences that will really tell us as to how vascular the tumor is. This will help us in gearing up for surgery and making our surgical plans very well. Vascular relationships, again, arteries, veins, and sinuses. Tumor some tumors are quite close to these areas, and in critical areas, damaging even the veins will produce serious side effects in terms of brain swelling, hemorrhage, seizures. Knowing those anatomical details before the surgery helps us a lot in producing good results in terms of surgery. So, surgical approach, just to give you an example of pituitary adenoma, by and large done endoscopically, and there are certain relationships that are quite critical, especially the carotids, how far the cavernous sinuses are involved. Uh, is there a dumbbell-shaped tumor that we need to avoid endoscopically? Are the vessels encased? So we need to know these details, and that we can do only with discussion with our colleagues. So for tumors like meningiomas, pre-op angiography and embolization is helpful for us. We can go through the images preoperatively, discuss all the anatomical details, and then at times very large tumors that involve the carotid circulation, we may have to do a test occlusion before surgery in case we have to occlude the blood vessels. We know beforehand that there's a good crossover circulation and the patient will not end up with a serious stroke. CT angiography is usually done if we just need the anatomy of the cerebral vasculature without any intervention. So that is good enough for us rather than doing full vessel angiograms for routine practice. So neuronavigation, this is a new tool that's been there for neurosurgeons for quite a while, and we routinely request specific sequences depending on the nature of the tumor, low grades T2, T1 with contrast, FLIR images. DTI's diffuse tensor imaging, again, is good for looking at the long tracks, projections, association, and commissural fibers. Functional MRI, again, a refined technique to look at functional areas like speech and movement, which is done without any special requirement in terms of details that we may need before surgery. Perfusion MRIs, I mentioned that is for increased vascularity, and diffusion MRI restriction indicates highly cellular lesions. So these sequences we may request especially for tumor surgery. So functional MRI utilizes the perfusion and utilization mismatch in terms of the oxygen delivery to the brain. And these areas can be picked up with special software for language dominant hemispheres, language areas in the inferior frontal gyruses, and the cortical mapping can be done only. So it doesn't give us the actual connection fibers in terms of the arcuate fasciculars or the superior inferior longitudinal fasciculus. It just gives us the cortical anatomical areas which are required for surgery. So this is an example of the diffusion tensor imaging where the fiber tracts are detected. You can see there's a low intensity area and the fiber tracts are pushed backwards. These are the cortical spinal tracts. So these images are then transported to our navigation system where we can again localize the tumor and plan our surgery. So case one, just an example of what we do. 70-year-old lady came in with cervical lymphadenopathy, history of fall 3 months ago. So this is a history. She has lymph node, then she has a fall, and then she develops a temporal mixed swelling. We do a biopsy. There's a mixed hereditary Hodgkin lymphoma. She also has fever and headache. So we have our MR. So we discussed this in detail, and we had three differentials. Is this a hematoma? Doesn't look likely. Is this a Hodgkin lymphoma that could have extended intracranially? Not likely, but certainly looks like an abscess. So very unwell child, and all we did was a biopsy and aspiration, and it turned out to be an abscess. Put on antibiotics, follow-up scans serially, and shows resolution. So we were hard pushed by our pediatric colleagues, go in and remove this. I said no. She's very unwell, multiple areas involved, and she's not going to do well with surgery. She'll bleed. So that's how it helps in our planning. His 30-year-old female, 6-month history of headache. This is good. 3-month history of tinnitus, intermittent left-sided numbness, and visual loss on the left side. So no motor sensory deficits on exam, left hemianopia. So the lesion is somewhere on the right side. So our favorite demyelination. So this was 3 months ago, and when she came to us, it was this. So the lesion has disappeared. So as Dr. Amr said, people do their own treatment as well. Maybe on steroids, we don't know really. So we were still not sure what it is. So inflammatory cells, lymphocytes, and plasma cells, along with areas of calcification.